which is what? Money. All right. So chapter 7. We're not going to go through the book straightforward. We will skip around a little bit. I tried to cluster all the chapters together that I thought were kind of related to each other. So that's why you'll see we're not going 1, 2, 3, 4. We're skipping to 7 this week. And 7 is enhancing long-term care. So here are just some of the objectives that I'm going to try to cover today. You obviously need to talk about why we need long-term care, why the needs are continuing to increase. Good morning.
Good morning.
We need to be able to easily identify the different payers for long-term care and talk about responsibilities and the government's role and how they reimburse. So, and just in case people don't know, LTC is long-term care. You'll see it abbreviated throughout the semester. So here's some of the administrative challenges. Obviously, we know our healthcare environment is changing daily, every day. We have a pretty diverse payer system, meaning there's different types of payers out there, different ways that people can pay for their services. We always have to worry about different laws and regulations that are changing. And especially nowadays, reimbursement is becoming more and more inconsistent, meaning you may not always know what the reimbursement is going to be the next day. It's always changing, it's not constant. As we talked about last week, here are some of the different settings: long-term care, nursing homes, in-home, assisted living facilities, adult daycare, outpatient programs, and community-based programs. Here are some of the skilled care services. So we have nursing, physical therapy, occupational therapy, speech therapy, nutrition, and social work. So these are some of the services that would require a payment for or reimbursement. So in some of the areas, you'll have a little bit of overlap. For example, you may find some overlap with long-term care with hospice support. Does everybody know what hospice is? Have an idea? Okay. And we have a chapter devoted to end of life and hospice, so we'll get more into hospice later on in the semester, but I want to make sure everybody knew what it was. Other ways that there's some overlap, maybe, I'm gonna let you guys give me an example. What do you think are some examples of overlap of services? What about if someone is having home care? Well, they may have multiple people coming in. They may have a physical therapist coming in in addition to their nurse's aide or whoever may be providing their home care. So that's an example of different services being overlapped. Remember that other types of services, like someone needing assistance with their daily living, can also count as well, such as needing help with the bath or going shopping or eating, those types of things, are more related to custodial care. So, as I said, we know that population is growing of baby boomers and elderly, and so how are we going to handle that? Or what are the contributing factors to making the growth so large? Number one is advances in medical technology. Obviously, as they do more research and develop more technology, they're going to find ways for us to live longer, right? Or be healthier or cure us of whatever we may be sick with. Now, it's somewhat of a perfect storm because some may have the inability to maintain their health, right? Or what if we're living longer, but can we afford the services that we need to stay alive, right? Because sure, okay, we'll go this way. How many of you all know somebody on Medicare? So we have 2 people. Out of these 2 people, do they still have to have things that they pay for out of pocket?
I know someone that's on Medicare, but they get assistance, and they living in like one of them long-term care homes, and they check. Just get deposited into a bank account, but they pay for their living there.
But as far as all of the services that they need, do you know if they have to, most people that are on Medicare still have to pay for some things out of pocket,
Yeah.
whether it's a drug or a
Copay for medicine.
copay or something. And so I said all that to say that some people may not be able to afford that out-of-pocket portion that they have to pay, even if they are on Medicare, which is obviously going to be paying for a lot of their services. So it can be a bit of a challenge. Sure, we're living longer, but can we, like I said, can we afford to pay for the services that we need to basically stay alive? So it presents some challenges. Which transitions into this, which I already started talking about. Here are some of the illnesses that we may have if we live longer. So Alzheimer's, everyone knows what Alzheimer's and dementia are. Diabetes, cardiovascular disease, cancer, Parkinson's. All of these are things that we could encounter if we live longer, which is why long-term care facilities can stay in business, because they will have needs that only long-term care facilities can satisfy. Balancing quality and service. So, we've had a few conversations already about the different levels of service in long-term care. We've talked about some facilities that aren't so great. We've talked about some facilities that are great. And they have to balance the services that they provide with quality. Some may say, well, as long as we get it done, that's all that matters. Well, no, there's still a certain level of quality that has to be there, especially if they wish to remain and get their reimbursements, or like we talked about with the surveys, inspections when people come in. So the quality has to be at a certain level. What this means is we can't duplicate services, which means we need to be efficient. We shouldn't have 3 people doing the same thing that one person can do on their own. We have to control our expenses, which again means we just can't be spending money on frivolous things. It should be spent on things that we need, and eliminating waste. So what that means is if there's a product that we have that isn't really being used, or a service that we have, that we offer that's not really being used, we should come back and analyze if we should continue to keep that or if we should get rid of it. We already talked about the growing need for long-term care. Here are some of the future predictions. So by 2020, it says 12 million Americans will need long-term care. 12 million will need long-term care, and 40% of the people over 65 will be cared for at home. Of the people that you know that are of age, how many of them want to go to a long-term care facility and how many want to stay at home? What do most of the people you talk to say?
Want to stay at home.
Want to stay at home? Anybody else?
I have one resident, I take care of it. She like being in long term because she feel like if she go home, she won't get the things that she need and her family members. You know what I'm saying?
So we
she
got
like it.
on both sides. So, which is pretty accurate to the numbers we have here because it's almost 50%. So you'll have some people that want to stay at home, and then you'll have some people that prefer to be in a controlled environment where they know that they can get the care they need. So U.S. government estimates that 40% of 13 million people that are receiving long-term care services are between 18 to 64. Remember we said that everyone that receives long-term care services are not necessarily 65 and older. Those that are 85 and older are now the fastest growing segment of our population today. So think about that. 85 and older is the fastest growing population. That in itself tells you how much of a need there's going to be for long-term care services. Yes, ma'am.
I used to work in a hospital in New York, and I used to be in this program called the House Call Program. And it's basically where the doctor go to the patient house. Have you heard of anything like that? Well, I haven't heard of it before I worked there. But I feel like if that program grows, then more people could stay at home and have the doctors and like the nurses and come to their house instead of going to a.
It's possible. I think that because we have such a large population of people that are getting older at the same time, there will be an increased need for home care, and physicians probably will start visiting homes more. But some of it's going to depend on what are they going to get for it. Is the reimbursement going to be the same as if they're going to a nursing home or a long-term care facility, or is it going to be less, or is it going to be more? So it's probably going to be dependent on that too, how the government chooses to pay them with reimbursements. Good question. Any other questions? So basically what this slide is telling you is to be prepared. We have a large population of, older people, baby boomers that are about to reach elderly age, and so there's going to be a huge need for long-term care services. Okay, so personal accountability. We obviously know that everything we do comes with a consequence, good or bad. And so here are some of the habits that directly affect people needing long-term care. Smoking. Why do you think this one? What happens? Why would they need long-term care? Breathing.
Cancer.
Asthma. So they could eventually develop cardiovascular disease, right? Or maybe they have, unfortunately, maybe they have a heart attack, and after that they need recovery assistance. So that's that one. Poor diet. We know that's obviously linked directly to cardiovascular disease and diabetes. We know that some people with diabetes have parts amputated. Lack of adequate exercise, to me that one ties into the poor diet. Belief that government primarily should care for the elderly and the ill. How do you guys feel about that? Should the government care for the elderly and the ill?
I don't really, if they have their families can take care of them. But I feel like that will tie into what we're going through now, where the retirement age is going up. So they're not going to really get their money back that they worked so long to go and even take care of themselves or go into a nursing home.
Right. Yeah.
So I think they are responsible for that part, but not like pay for it and take care of them.
Okay. Well, there's some. Yeah.
There should be a bit of a fine line between care and helping. That, well, you do want to help them, but there is another time where if someone's older, they might take advantage of the situation.
Okay, so you should be a balance.
A bit of a balance.
Okay, all right. Well, there's some belief that they should take care of them completely, but again, if we go back and we think about those numbers, we're talking about lots and lots of money if this were to happen. We're talking about millions and millions of people that will need care. So we will have to kind of analyze it and figure out some type of balance, see how that can work. So how can we deal with some of the things that we just talked about? Because most of us know people or ourselves, can check off something from this list, right? So one thing we can do is we can secure our life insurance, right, for ourselves or for our loved ones. You can also purchase long-term care insurance. Does anyone familiar with long-term care insurance? Basically, it's very similar to a regular insurance policy, but it's related to long-term care. So you would, just like you do with your other insurance, you pay a portion every month or twice a week or whatever, and it goes into a pot for that long-term care. So for instance, if I had a parent that was getting older and I wanted to buy a policy for them for long-term care so that they would be set up once they reach that age, I could do so now. And some people do that. It's usually like one of those supplemental insurance options that they offer you separate from your regular insurance. Did you have a question?
I did. I guess you answer it with the, can you purchase it now and then have it later on?
Yeah. And the popularity or the demand for this is starting to rise because of the fact that more and more people, those baby boomers, are reaching that retirement age. So this is becoming more popular. Any other questions about that long-term care insurance? Before we get into talking about numbers a little bit more, I want to make sure you guys understand, number one, what expenditures means. Everybody understand what an expenditure is? I think a few of you guys have taken accounting. Basically, as it says here, costs related to funding productivity. And productivity is basically, up here it says a ratio of output to input, but put in simpler terms, this is basically a measurement of the work that's being done. So if Bradley is supposed to care for 8 patients an hour and do the same thing for each patient, and he is only doing 3 an hour, his productivity is low because he's not hitting the 8. Now, if he's supposed to be doing 8 and he actually does 12 an hour, his productivity is really, really high. So it's basically a measurement of what you're doing, what the work is, how much work you're putting out. Now, we're reviewing this because it's very important when it comes down to money. Obviously, you want to keep your expenditures low, and you want to have your productivity as high as possible. Now, keeping that in mind, we don't want to have our productivity so high that we lose what? What might we compromise if our productivity is too high?
I know I just say it. I don't know what I'm trying to say.
But you say your productivity is too high?
Yeah, what might be compromised if our productivity is too high?
The care.
The care might be compromised. If we're going too fast, our level of quality may not be where it is. If we're thinking in terms of something you're more familiar with, if you're going too fast with your billing and coding, errors may occur, right? So I said all that to say, while we want to cut our costs and want our productivity to be high, we don't want it to be too high to the point where we're compromising other things that are more important, like patient safety or patient care, or their quality, the level of quality that we're providing for our patients. So basically, you will have a financial plan, and you'll update this regularly, and the plan will include an estimate or projection of your budget, what your expenditures are going to be, what your productivity level is going to be, and typically you predict this every year. So if it's 2014, we're going to be forecasting out into 2015. And we evaluate everything. We look at the staff and what they're spending in direct services. So direct service being an activity that directly benefits the client or caregiver. So bedpans. If we find that our staff is spending way too much time changing bedpans or switching bedpans out, that's something we need to reevaluate, right? That would be a direct service. That's something we provide to the patients directly. An indirect service might be what? Can you think of an example? Should be 1 or 2 in your book. We know the definition is activities that result in no direct benefit to the client or caregiver. But let's try it. Someone tell me an example of an indirect service.
Wouldn't it be like volunteering or something like that?
You said,
Where you tell the client, okay, no, never mind.
Would it be like something like the activities maybe that goes on in the nursing home?
possibly
No, 'cause-
activities or the facilities. You still have to
Right.
keep the floors clean, the
Yeah.
rooms clean, those types of things. It's not a direct service to the patient, but it's still a service that's
Right.
necessary for us to operate, right? So how do we measure productivity? Well, there's a few different ways. First, patient outcomes. We can look at falls, how many falls we had, per month, per week, per year. Errors, medication errors, medical errors. Why might these things help us to measure productivity?
Well, to see if we're doing our job in the correct manner and making sure that there are no accidents and making sure
Right.
paperwork's organized.
Right. So if we have a high number of falls, what might that tell us about our productivity?
It's
Paying
down.
attention.
It's really low, or what do we just talk about?
They moving too fast.
It could be too high.
It's too high.
Either way, we know something's wrong with the productivity if we have a high number of falls or a high number of errors. So one way is through patient outcomes, and then another way is financial outcomes. So positive bottom line basically means we're making money. If we have a positive bottom line, we're making money. So let's stop there for a minute. Why would a positive bottom line mean that we're being productive, or means that we have a good productivity?
Performing all our services in a correct manner, that we're not going too slow or too fast.
Okay, so we're
Great pace.
performing our services at the right level, okay? What else could we be doing? We could have found ways to be more efficient, right? Maybe we found ways to shave off 5 minutes of that duty that we're supposed to do. Anytime we can save time or make ourselves more efficient, it's going to affect our bottom line and make us more money. Or maybe we figured out a way to save supplies, and so we're not spending as much supplies anymore. So we're being more resourceful. Those are all ways that we can have a positive bottom line, which will directly tie to our productivity. Avoiding fines and penalties. So we'll talk about this one too. We talked about how we can have surveys and inspections and people come in. Well, if we're doing everything we need to do and we're getting checks on our surveys, we're avoiding fines and penalties, right? Which will directly tie to us making more money, and it will show that we're being productive. We have a good level of productivity. And then the last one says positive referral patterns. Everybody knows what referrals are, right? Referral is if Kayla's uncle is in the long-term care facility and he's having a great experience. And they typically say that when people in any industry are having a positive experience, they're going to tell other people about it, right? But they also say that if people have a negative experience, they're going to tell people. So who do you think tells more people? The positive experience or a negative?
The negative.
The negative. And the numbers show that too. If someone has a negative experience, they're going to tell more people than someone with a positive experience. But if we have somebody with a positive experience and they tell other people, and as a result they come to our long-term care facility, this is also going to affect our bottom line, which will directly tie into our productivity. So do these make sense? So these are 2 ways that we can measure how we're doing, basically. We can look at our numbers, how much money we're making, and we can look at these 3 things. We can look at our patient outcomes, how are our patients doing. So they're gonna both tell us how we are doing as employees. Here are a few different tools that we use to measure productivity. We look at our resources and the costs. Case mix index, we talked about this before. Case mix is basically, it tells you basically what your population is within your facility based on acuity level. Occupancy percentage. If we have a low occupancy percentage, what might that mean? What does that mean?
That means there's not a lot of people, well, not a lot of patients.
Right, so it's not a lot of patients. So what happens during that time?
You lose money.
We lose money, right. So if occupancy percentage is a way to measure productivity, we want this to be a high number. This should be, you want a high occupancy percentage. What about patient census? We talked about this too. This basically tells us at any given time how many people are in our facility. So we want high and low. We want high. These 2 kind of tie right into each other. Your occupancy is occupancy percentage is basically a percentage of your patient census. And usually this is taken on a weekly or monthly basis, the occupancy percentage. Census is usually taken daily. So we want both of these to be high, because if they are, then in most cases, it's going to show that we're being productive. We have a high level of productivity. And then the last tool we can use to measure our productivity is we can check ourselves against other people. How is X long-term facility doing compared to ours? Are they doing better? Are they doing the same? Or are they doing worse? If they're doing better, it may tell us that our productivity is not that great. We may think that we're doing a great job, but if we look outside at other facilities on a local, state, or national level, we may find that we're not really doing that great. And so benchmarking is another tool that we can use to see how we're doing, how productive we're being. Costs and expenses. We all know what costs and expenses are. We all have them individually. Cost, the formal definition is defined as resources used to produce a good or a service. So, and then expense is defined as a measure of the resources used to generate revenue or provide a service. So everybody understand the difference between cost and expense. So expense is a measure of the resources, and cost is the actual resources used to produce the good or service. Typically, you'll see the term expense more than cost in healthcare, but the book wants you to understand the differences between both. Both we want to keep down if we want to make money. Everybody understand that though, right? Now capital expenses are a little bit different. Capital expenses are typically your larger expenses. So if you are doing renovations, or maybe you're expanding your facility, or if you're buying items that are expensive, really expensive, it'll go under a capital expense. Also, capital expenses are typically things that are going to last you for a while. So napkins are not going to be a capital expense. They'll be an expense, but not a capital expense. Now, a new toilet would be more of a capital expense because it's a larger expense, or new toilets for your entire bathroom. It would be more of a capital expense, and it's something that's going to last you over time. Usually, capital expenses are things that are financed. You don't just pay for them with cash. So if there are larger things that the facility is going to have to make payments on over time, it'll probably fall under the capital expense. So there's two different types of organizations. Everybody understand what for-profit and nonprofit are? Yes? Okay. I want you to understand that within long-term care facilities, there are both. You have some that are for-profit, some that are nonprofit. Obviously, the two types of organizations operate differently. They have different goals. Those that are for-profits will have to answer to their shareholders. Those that are nonprofit will not be as concerned about hitting those targets, hitting those budgets, or making that certain amount of money as those that are for-profit are.
Will the care clinic be a nonprofit?
Yeah. Yeah, good example. This chart is also in your book, but it shows you inflation rate. If you guys can't tell by going to the grocery store, inflation is rising. So they have different types of settings here: nursing home, assisted living, home care, adult daycare. Here you can see the percent increase from the previous year, and this is from 2009 to 2010. So nursing homes increased 4.6%, assisted living 5.2%, home care and adult, there was no percent change. But think about this. Come over here to the cost. If we think about how much it costs on an annual basis for someone to go to a nursing home or an assisted living, 4.6% may not seem like a lot, but it's a lot of money, right? So this is important for us to see. Why? Because we have costs that are continuing to increase, is going to directly affect who comes to us. If inflation has increased this much, you may have patients that you lose because they say, I can't afford to stay here anymore, right? So this is very important to understand and keep a pulse on the inflation that rises every year, because long-term care is such an expensive thing. We talked a little bit about case mix. Here it is again. Like I said, it's an indicator of the different types of patient conditions you have in your facility. The reason that case mix is important because it is usually directly related to how much money you get. Obviously, the more acute patients you have, the more funding or more money you'll get. The less acute patients you have, or the lower your case mix number is, the less money you get, which makes sense because people that are sicker will require more. They'll require more drugs, more care, more resources. So that's why the case mix is very important, because it's directly tied to your reimbursement and how you get paid. Now, with that being said, you may say, well, I want my CMI to be really high. Why wouldn't you want a CMI that's really, really, really high? You still have to be able to manage it, right? If you have nothing but patients in your facility that are all 10s, who's going to be able to, can you care for everybody if everybody in your facility was at the highest acuity level? Would you have the staff to be able to take, right? So you want to have a high CMI, but at the same time, you have to be sensible and know that you do need a mix of patients. You can't have all extremely sick patients. You won't have the staff and the resources to take care of all those people. Or if you try to, you're just going to lose money on the staffing side because you're going to have to hire so many people to bring them in. So it's important that you understand that your CMI is related to your payments, but also understand that you need to have a good mix. What that may mean is you as a facility or as an administrator may decide, I'm only going to have 3 10s, 4 8s, 5 3s. That's the mix that I need for my facility. So those are the types of things you have to determine to make sure that you can still get a decent reimbursement, but also you're not overworking your staff, because then they're going to leave, and we all know how turnover goes. So here's some considerations in evaluating CMI. Again, you want to look at the services being provided, look at the cost that it takes to provide that service versus how much are you going to get paid. So it goes right back to what I said. If you have a certain number of patients or your CMI is so high to the point where you're going to spend more to provide services for them and not get it back in reimbursement, you may need to change up your case mix. Cost shifting opportunities between payer sources. So in what ways can we shift some of that cost off of us onto the payers? And then balancing patient types to maximize reimbursement, kind of what we just talked about. You probably want to try to figure out how many of each acuity level that you want to have with your patients to make sure that you can get money in and still make a little bit of money. Occupancy and census, this will be the last slide I cover. It's a calculation. Basically what you do is you want to take the total number of beds you have in your facility, multiply it times the number of days to get your residence days. So here's an example. Maybe your facility has 175 beds, multiply times 30 days, 5,250 would be the possible resident days. Once you have that, then you want to multiply the actual number of beds filled. Everybody know what beds filled means?
People in the bed.
People in the bed. So just because your facility has 175 beds, they may not all be full. Maybe you only have 100 patients. So in this example, we say we have 150 full beds. We multiply that times 30 days to get 4,500. So then what we do is we divide the actual resident days, 4,500, by the 5,250. This gives us our occupancy rate. So we just talked about occupancy and how the higher our occupancy rate is, the better we're doing. If our occupancy is low, that means we don't have anybody in the beds and we're not making as much money. Does that make sense? So these are the kind of calculations you're going to have on a monthly basis, annual basis, to see how productive you're being, see what your level of productivity is. Any questions about how this is calculated?
So is that 85.7 good?
Well, it would go back to, we talked a little bit about benchmarking. We may look at this and say, that sounds good to me, but then if we go down the street and talk to the nursing home or whatever down there, they may say, we're averaging 95%.
Okay.
So it may look good at first, but we may need to take this number and benchmark it against other facilities to see what their number is. And we can do that at a local level, somebody on the street. We can see what the state average is in North Carolina, see what there's the average occupancy rate, or we can benchmark it against the national number. Then once we know what those numbers are, we can come back and determine if our number is good or not. Or the other thing we can do is, if we know last year was 95 and it's 85.7 now,
Something wrong.
we know that it's gone down. So we can also compare it against ourselves.
I'm sorry, I got a test.
Yeah. So we can also compare it against ourselves. Now, the other thing you can do with this number is, we talked earlier about forecasting and projecting. We can say, okay, this year we had 85.7. Well, this will come down to us setting our goals. Maybe we want to say next year we want to have 90%. So what do we need to do to get it up? And so then we may go back and evaluate our marketing, other ways, our referral system, to see how we can get this number up. Does that make
Get some
sense?
beds filled, get some more beds filled.
Yeah. Anybody else? Any other questions? All right, we're gonna stop here. I'll see you guys on Thursday. We can back it up.
Or she said she wants us all to do everything in time.